WBC पढ़ेंगे. So basically WBC is divided into two categories. First one is granulocyte and second one is agranulocyte. So granulocyte में 3 types के WBCs आते हैं. First one is basophil, then eosinophil and then neutrophil. Whereas agranulocyte में 2 types के WBC आते हैं, lymphocytes and monocytes. तो इसको याद करने का तरीका, निमोनिक क्या बनाया हमने, लता मंगेशकर बेन. लता मंगेशकर से हो गया लिम्फोसाइट, मंगेशकर यानी मोनोसाइट, एंड बेन. बेन गुजराती में बेन यानी बहन हो गया ना. तो बेन में बी फॉर बेजोफिल, ई फॉर इयोसिनोफिल एंड एन फॉर न्यूट्रोफिल. अब हम देखेंगे कि इसको स्लाइड पे आइडेंटिफाई कैसे करते हैं. तो फर्स्ट ऑफ ऑल न्यूट्रोफिल. न्यूट्रोफिल को कैसे आइडेंटिफाई करना है. देयर आर 3 to 5 न्यूक्लियर लोब्स इन न्यूट्रोफिल. तो यहाँ पे जैसे 3 लोब्स दिखा रखे हैं. देन लिम्फोसाइट हो गया हमारा. उसके बाद एक और लिम्फोसाइट का ही एक वेरिएशन है, बैलेरिना स्कर्ट अपीयरेंस. सो इसमें बेसिकली जो लिम्फोसाइट की जो बाउंड्री है वो बेसिकली बैलेरिना स्कर्ट की तरह बाउंड्री दिखेगी. तो बेसिकली इसको हम बोलते हैं डाउनी सेल्स, विच इज़ सीन इन इन्फेक्शियस मोनोन्यूक्लियोसिस एंड एप्स्टीन बार वायरस इन्फेक्शन. देन नेक्स्ट वन इज मोनोसाइट. मोनोसाइट में हमें रेनिफॉर्म न्यूक्लियस और वी कैन से किडनी और बीन शेप न्यूक्लियस दिखेगा. तो ब्लड में अगर ये दिख रहा है तो वी विल कॉल इट मोनोसाइट, and if it is seen in tissue then we will call it as macrophages. After that plasma cell. तो प्लाज्मा सेल के डिफ्रेंशिएटिंग फीचर्स 2 हैं. सबसे पहले इसमें जो न्यूक्लियस होता है वो इट इज़ नॉट प्रेजेंट इन द सेंटर, इट इज़ प्रेजेंट away from the center. So this type of nucleus is called as eccentric nucleus. And next one is perinuclear HOF. ये जो दिख रहा है स्पेस, इसको हम बोलेंगे पेरी न्यूक्लियर हॉफ. न्यूक्लियस के जो सराउंडिंग में स्पेस है इट इज कॉल्ड एज पेरी न्यूक्लियर हॉफ. दिस इज ड्यू टू गोल्गी, इंक्रीज गोल्गी की वजह से ये पेरी न्यूक्लियर हॉफ दिखता है. एंड इलेक्ट्रॉन माइक्रोस्कोपी पे हमें कार्टविल क्रोमैटिन दिखेगा. देन नेक्स्ट वन इज इयोसिनोफिल. तो इयोसिनोफिल में हमें स्पेक्टिकल शेप्ड न्यूक्लियस मिलेंगे एंड देयर इज ऑरेंज रेड granules. So this is how we will identify eosinophil under microscope. Next one is basophil. Basophil में है blue black coarse granules मिलेगा, जैसे you can see blue black coarse granules. And in NEET नीट में क्वेश्चन पूछते हैं कि what is the special stain used for staining basophil. So it is toluidine blue. ओके. नेक्स्ट अब हम WBC एबनॉर्मैलिटीज़ देख रहे हैं. तो जनरली हम इसको क्लासीफाई करते हैं नॉन न्योप्लास्टिक एंड न्योप्लास्टिक में. सो नॉन न्योप्लास्टिक सबसे पहले हम पढ़ रहे हैं. तो इसमें सबसे पहले आता है हाइपर सेगमेंटेड न्यूट्रोफिल. जनरली न्यूट्रोफिल का अभी हमने बोला कि 3 to 5 हमें न्यूक्लियर लोब्स दिखते हैं. बट इफ़ वी सी मोर देन 5 लोब्स देन इट इज़ कॉल्ड एज हाइपर सेगमेंटेड न्यूट्रोफिल. सो यहाँ पे आप देख सकते हैं, एज यू कैन सी मोर देन 5 न्यूट्रोफिल लोब्स मिल रहे हैं. एंड दिस इज जनरली सीन इन मेगैलोब्लास्टिक अनीमिया. आफ्टर दैट हाइपोसेगमेंटेड न्यूट्रोफिल. सो इफ लेस देन 3 nuclear lobes are present, we will call it as hyposegmented neutrophil, and it is seen in Pelger-Hydet anomaly and Pseudo-Pelger anomaly. Pseudo-Pelger anomaly is basically in conditions like MDS and CML. If hyposegmented neutrophil is seen, we will call it as Pseudo-Pelger anomaly. Next pathology is May-Hagelin anomaly. In this, we will find giant platelets, and there is low platelet count and inclusion in the granulocyte, which is called as Dohle's bodies. So the mnemonic to remember is this. Remember, this is is GLIN. G for giant platelet, L for low platelet count, and IN for inclusion in granulocyte. And the gene involved is MYH. Take this MYH 9. Okay, so here you can see giant platelet and inclusion bodies. These are the inclusion bodies. Next one is large cytoplasmic granules. So you can see large cytoplasmic granules, which is seen in Shediac Higashi syndrome. And after that there is large cytoplasmic granule, which is also seen in Alder-Rayleigh's anomalies. These are large cytoplasmic granules, but the difference in these two is these large cytoplasmic granules in these two large cytoplasmic granules is that the large cytoplasmic granule which is seen in Alder-Rayleigh's anomalies, these are normal functioning cells, whereas the one seen in Shediac-Higashi syndrome, these are abnormal cells. Okay. Abnormalities. Neoplastic 1. Here we will study leukemias, lymphomas, plasma cell disorder, and LCH. So basically, first we will study a difference between myeloblast and lymphoblast. The myeloblast cells are larger in size. It has granules. There is presence of Orr's rod. These are Orr's rod. And there is presence of nucleolus. Whereas the lymphoblast cell is smaller in size as compared to myeloblast. There is absence of granules, Orr rods, and nucleolus. The stains used for staining myeloblast and lymphoblast are MPO Sudan black B is used for staining myeloblast, whereas sparse positive and acid phosphatase is used for staining lymphoblast. So next type of cells which we need to differentiate under microscope is faggot cell. In faggot cell, there are multiple Orr rods, as you can see here, and it is generally seen in AML M3 type, that is APML. We will discuss this in detail in later time. Okay, now the next cell is promyelocyte. Promyelocyte is comparatively larger. Then there is myelocyte. In myelocyte, the nucleus is D-shaped. After that, metamyelocyte. There is slight indentation in the nucleus. Then band or staff form. There is more indentation in the nucleus. Comparison table which compiles all types of cells. This is promyelocyte, this is D-shaped nucleus, myelocyte, metamyelocyte, band shape, staff form, and all. Now we will move forward to individual topics. Like first we will read acute myeloid leukemia. Okay, so in acute myeloid leukemia there is FAB classification. M0 means AML undifferentiated, M1 means AML without maturation, M2 is AML with maturation, M3 is acute promyelocytic leukemia, M4 is acute myelomonocytic leukemia, M5 is acute monoblastic leukemia, M6 is pure erythroid leukemia, M7 is acute megakaryocyte leukemia. Okay, now we will make mnemonics to remember this table. Okay, so first of all, जब दो लोग मैच्योर हो जाते हैं तब उनकी शादी हो जाती है. ओके, सो M2 इज AML विथ मैच्योरेशन और शादी की एज क्या है 21 ईयर्स. सो देयर इज ट्रांसलोकेशन ऑफ 821 एंड शादी होने पे नज़रें मिलते हैं. दैट मीन्स देयर अकर्स ऑर्बिट क्लोरोमा. एंड शादी इंडिया में बहुत कॉमन है. सो दिस इज द M2 इज द मोस्ट कॉमन टाइप. नेक्स्ट वन इज M3 3 letter word DIC. So M3 is associated with DIC. It is acute promyelocytic leukemia. There is translocation of 1517. So pro से we should remember 15, pro 15. and there is presence of faggot cell. There is association of PML RARA gene and ETRA. Next is M4. M4 is acute myelomonocytic leukemia. So M4 ko we can write it as 2 into 2. So there is presence of double esterase, and it involves 4 into 4 is 16. It involves inversion 16. There is tissue infiltration in it. It means the cells involve gums and skin. Same is M5. In M5 also there is double esterase involvement. Then we remember it as acute MONA. So acute monoblastic leukemia is associated with leukemia cutis. Then M6, pure erythroid leukemia. Then M7, acute megakaryocyte leukemia. It is associated with it is generally seen in Down syndrome in children below 3 years of age. Okay, so the next topic is acute lymphoblastic leukemia. ALL generally occurs in children, and lymphoblast, how to identify lymphoblast? There is scanty cytoplasm and pass positive cells. So how to remember this? Child ko pass bulao. Child, that is it is most common pathology in child is ALL, and pass below is pass positive. So there are two types of ALL: good prognostic one and bad prognostic one. So how to remember this? It's better to remember one table, so the other you can also point out which one is bad one. So the good prognostic one are mnemonic to remember it as Preeti Beti rank 1, everyone happy, 21 years pay. So Preeti Beti se you can remember as pre B cells are having good prognosis. Rank 1 is L1 having good prognosis. Everyone happy, yani everyone happy, that means hyperdiploidy is good prognosis. 21 years age, that means T1221 is of good prognosis, and 1 to 10 years is considered as good prognosis, whereas less than 1 year or more than 10 year T cell acid phosphatase positive, if it affects mediastinum, brain and testes, L2, and male, if the pathology occurs in male, hypodiploidy, T922, T411, these all are of bad prognosis. Okay, so the next one is chronic myeloid leukemia. Okay, so the etiology for chronic myeloid leukemia is translocation of 922, that is BCR ABL fusion, which causes tyrosine kinase increment, hence leads to chronic myeloid leukemia. The clinical features here is massive splenomegaly, which causes dragging sensation. It is divided into 3 phases, which we will remember it as CAB. C for chronic, when the blast is less than 10%. A for accelerated, when the blast is 10 to 19%, and basophil is more than 20%. B is blast crisis, when the blast is more than 20%. Lab score, here the lab score is low. The normal value is 40 to 100, but here it is less than 40. Treatment for is tyrosine kinase inhibitor, that is imatinib. Here you will see under microscopy garden party appearance or college girl appearance. Garden party in the sense there are different types of myeloid cell, as you can see, and on bone marrow biopsy you will find pseudo-Gaucher cell. Now we will go to the chronic lymphocytic leukemia. It is due to deletion of 13q. It is not associated with radiation. Criteria to call it as CLL is in blood if the acute lymphoblastic count is 5,000 per mm cube. In bone marrow if the lymphocyte is more than 30%, or the flow cytometry is positive for CD5, CD23 and CD200. In peripheral smear you will see smudge cell. Okay, so now we will see this how smudge cell looks like. Okay, there is smudging of the cell. As you can see, this is also called as basket or parachute cell. This smudging is due to absence of vimentin. Okay. The syndrome associated with the CLL is Ivan syndrome. In Ivan syndrome, there is autoimmune hemolytic anemia plus CLL plus immunothrombocytopenic purpura. The second syndrome associated is Richter syndrome. And Richter syndrome, CLL or SLL convert to DLBCL. Okay, some one-liners. Most common which occur in children is ALL. Most common blood tumor in associated in Down syndrome is ALL. Most common in Down syndrome within 3 years is AML M7. Most common in adult is AML. Most common with radiation is AML. Most common in elderly and in West is CLL. Not associated with radiation is CLL. Associated with deletion 13q is CLL. Okay, so here this is how the garden party appearance in CML look like. Here you can see indentation in the nucleus, D-shaped nucleus, little indentation in nucleus. All kinds of cells are present. That is why it is known as garden party appearance. Now we will come to Hodgkin lymphoma. So Hodgkin lymphoma is divided into two categories. First is classical Hodgkin lymphoma and second is non-classical Hodgkin lymphoma. Classical Hodgkin lymphoma, we will remember it as LLMN. L for lymphocytic rich, lymphocytic depleted, mixed cellularity and nodular sclerosis. Lymphocytic rich. In these types of lymphoma, you will find mononuclear cells. In lymphocytic depleted, you will find mummified Reed-Steinberg cells. It has worse prognosis. Then next one is LLM, mixed cellularity. So in India, there is mixture of people present. That is why it is most common in India. This is how we can remember it as. And it is associated with classical Reed-Steinberg cell, the classical owl's eye appearance, which we will see further. And most common it is associated with EBV and HIV. Next one is nodular sclerosis. It is most common seen in world. There is presence of lacunar cells. It has best prognosis in classical HL. The classical HL, all the subtypes of classical HL has CD15, CD30 and PAX5 positive. Okay, and all of them is EBV positive, associated with EBV infection. Now the next one is non-classical Hodgkin lymphoma. It is EBV negative, CD15, CD30 negative. There is presence of CD20, CD45, EMA, BCL6 positive. So there is one subtype of non-classical Hodgkin lymphoma, that is nodular lymphocytic predominant Hodgkin lymphoma. There is presence of popcorn cells and it has the best prognosis overall. This is how classical Reed-Steinberg owl's eye appearance look like. This is how lacunar cells look like, and this is how popcorn cell, which is found in LLPHL, look like. Now we come to non-Hodgkin lymphoma. Non-Hodgkin lymphoma is further divided into B cell non-Hodgkin lymphoma and T cell non-Hodgkin lymphoma. B cell non-Hodgkin lymphoma has further 7 variation and T cell has further 2 variations. Okay, so first we will study B cell non-Hodgkin lymphoma. This is the lymph node diagram. So if there is lymphoma of naive B cell, we will call it as CLL or SLL. If the lymphoma of mantle zone lymphoma, if there is lymphoma of germinal cell lymphoblast, we will call it as follicular lymphoma, DLBCL, and Burkitt. Then marginal zone lymphoma, plasma cell B cell is known as multiple myeloma. Okay, so there's a NHL trick how to remember this. First write 8, 11, 14, 18. 8 look like B for Burkitt. So in Burkitt lymphoma there is translocation of 814, 822, 28, except 821. 821 translocation is seen in AML M2 and it is associated with c-MYC gene. Next one is 11. So 11 and 18 are numbers at margin. So translocation 11, 18 is seen in marginal zone maltoma. Then 11, 14 it is mantle zone lymphoma, and 14, 18 for F for 14, F for follicular lymphoma. Okay, now approach to NHL. Now we will study approach to non-Hodgkin lymphoma. So first of this table, if CD5, CD23 and CD200 all of three are positive, then it is CLL or SLL. If only CD5 is positive, then it is MCL, that is mantle cell lymphoma, or if all three are negative, then it is marginal zone lymphoma. So here CD5, 23, 200 all three positive, CLL or SLL, where we can see smooth cell if CD5 only positive, CD23 negative, cyclin D1 positive, SOX 11 positive, cleaved or buttock cells, lymphomatoid polyposis, translocation 11-14, then it is mantle zone lymphoma. If all three negative, then marginal zone lymphoma, which is generally seen in Sjogren and Hashimoto's. Okay, now we will come to this part, germinal center wala. So in germinal center wala part, we can see there are three. It is associated with three types of lymphoma. So we will differentiate all three types of lymphoma. If CD10 BCL6 positive, then it is DLBCL. If 6 people study together, group study, then it become a disaster. That is how we can remember it as. So diffuse large B cell lymphoma, it is most common NHL, most common aggressive, most common extranodal and associated with EBV. If c-MYC positive and Ki67 100% present, starry sky appearance, jaw swelling and abdominal mass present, then it is Burkitt cell lymphoma. If CD10 positive and BCL2 positive, if 2 people study together, it is the most fruitful one. So this is how we can remember. It has good prognosis. So it is best prognosis, and this is follicular lymphoma. So that is how we covered all B cell NHL. Now we come to T cell NHL. So if CD3 positive, that means it is a T cell, and in T cell there is cutaneous T cell lymphoma, which is also called as mycosis fungoides. Here we can see portrait microapsis. There is presence of cerebriform nucleus. So here we complete approach to NHL. Now we come to multiple myeloma, this part. Multiple myeloma. Okay, so multiple myeloma, it is a cancer of plasma cell. What is the criteria to call it as multiple myeloma? In bone marrow, plasma cell is more than 10%, immunoglobulin is more than 3 gram per deciliter, and there is myeloma defining events, which is remembered as mnemonic Crab's limb. C for calcium increase, renal insufficiency, anemia, bony lytic lesion. S for 60%, plasma cell is more than 60%. Li is for light chain involvement more than 100. M for MRI, that is there is focal lesion of more than 5 mm. So as we said, bony lytic lesion. So here you can see there are punched out lesion, and in blood findings you can see Rolex formation. Okay. So the next is composition of composition seen in bodies which is present in multiple myeloma. So first of all, there is some intracytoplasmic body which is known as Russell body, and intranuclear body which is known as Dutcher cell, and there is Mulberry or Mott cell as you can see, and flame cell. These all findings you will see in bone marrow aspirate. In bone marrow biopsy you will see sheets of plasma cell. Sheets of plasma cell. When you will do electrophoresis, there is M spike. Presence of M spike. M means myeloma or monoclonal spike. Okay. The next one is plasma cell leukemia. When the peripheral blood have more than 20% plasma cell, it is called as plasma cell leukemia. So that's all for WBC. Hope you enjoyed learning. Please do give your feedback. Thank you and have a nice day.